First of all, I want to thank the organizer for the kind invitations, particularly Professor Lesmana. It's always a pleasure to come to Bali, and I want to congratulate Apazal as well for running the meeting despite all the health issues. So my task within the next 20 minutes will be to deal with a non-invasive assessment of portal hypertension. It's been a field of very active research over the past years. So this is the outline I will be following: available non-invasive tests, identification of patients with clinically significant portal hypertension, identification of patients with esophageal varices, and also identification of patients at high risk of portal hypertension-related complications. So these are the available non-invasive tests: biological and physical approach. I think you're all familiar with this slide. So we have non-patented and patented tests. I don't have time to go into detail. And physical approach, for which transient elastography has been the pioneer, but now there are other kids on the blocks, such as RFE, 2D shower wave elastography, and MR elastography, even though we have very few data regarding MR elastography in the field of portal hypertension. Please take into account the availability that is inverse opposite of cost for these different techniques. Okay, now we have large meta-analysis because we start with the diagnosis of cirrhosis, and you can see FIB4 and APRI are the two best validated tests, mostly in viral hepatitis. And as for elastography, among the different techniques, you can see several thousand of patients, including all etiology, and transient elastography is the most validated and most used worldwide. So CACLD has been proposed now 5 years ago by the Baveno 6 meeting, and you can see when the liver stiffness is at 10 kilopascal, the negative predictive value is high, around 90%, to rule out CACLD. When it's above 15 kilopascal, the positive predictive value is high, 90%, and as it is a continuous value, it should be used as a probability, and you see if you increase the liver stiffness value, the probability increases. On the opposite, if you decrease the value, the negative predictive value is increasing. So these are the EASL guidelines published now 5 years ago, and I just want to stress that we're in the process of updating them, and they should be presented at the next ILC meeting next month in London, if we can run it. And when your diagnosis of CACLD is done, you don't need a confirmatory liver biopsy, and you can check for portal hypertension. So the two reference tests has been already dealt with by Guadalupe Garcia-Tsao, endoscopy for esophageal varices and HVPG for CSPH. And these are the tools we have. So what about patients with clinically significant portal hypertension? So this is how you stratify your patients according to HVPG, according to different value, and CSPH is defined HVPG above 10 millimeter of mercury. So, as I mentioned before, we have meta-analysis, decent number of patients, over 1,000 for liver stiffness using transient elastography, and you can see OROCs are excellent for detecting CSPH. Actually, liver stiffness is better at ruling in than ruling out. This is a larger study from Vienna, and you can see that the predictive positive value is better than the negative predictive value. However, we have to be aware of the limitation of this study because most of them are conducted in expert centers with likely referral bias, and studied populations are very heterogeneous with small sample size and high prevalence of CSPH. So what about combining liver stiffness with other marker? This is a so-called LSPS, liver stiffness spleen diameter to platelet ratio score. This is the way you calculate it. And this has been validated with other scores like the PH3 score, and basically you can see that you increase the diagnosis accuracy when you're combining liver stiffness with other marker. And actually what you're doing is you're decreasing the number of undefined between the two cutoffs. So this is another study, the so-called Anticipate study that came later. And again, you can see if you add platelet to liver stiffness or LSBS, you increase the diagnosis accuracy. What about the new technique? 2D shear wave elastography is the best validated. We have a meta-analysis recently published, decent number of patients, even though it's below 1,000. And again, you can see the ROCs are good, 0.88. This is our study from our group, and you can see when we compare shear wave to transient elastography for CSPH, there was no difference. Same result from the Barcelona group showing no difference in terms of ROC between transient elastography and shear wave elastography. So just to summarize, liver stiffness measurement using transient elastography has been the most studied so far to identify patients at risk of CSPH, better at ruling in than ruling out. And when you combine with other markers, such as LSBS, you increase the diagnostic accuracy. So as a result, these were the Baveno 6 recommendation, and the cutoff should be above 20 kilopascal, 20 to 25. Then 90% of your patients will likely have CSPH. What about now esophageal varices? Again, large meta-analysis for esophageal varices and large esophageal varices. You can see the ROCs are slightly lower for large esophageal varices using transient elastography. And this is the initial study in terms of prediction of large esophageal varices. And what you can see on this study, the cutoff at that time was 19, so close to 20. Again, better this time at ruling out than ruling in. So in other words, negative predictive value is much higher than the positive predictive value that is pretty poor in this study. What about LSBS that I mentioned? Again, you can see that the number of Sayer per GI, you're higher than using transient elastography alone. This is the Anticipate study, and again, you can see the OROCs are much lower for esophageal varices than for CSPH, but you increase the OROCs when you're combining liver stiffness with other marker. So, to summarize, liver stiffness using transient elastography is better at ruling out and ruling esophageal varices, but cannot completely replace upper GI endoscopy, and this is why rules have been defined, and when you combine especially with platelet count and ultrasound, you increase the diagnosis of accuracy. What about shear wave versus transient elastography? Again, in this study from our group, there was no significant difference when you compare. Another study with a larger number of patients, and again, you can see there was no difference between liver stiffness and shear wave elastography. So, as a result, the Baveno 6 recommendation were proposed 5 years ago, and if your liver stiffness using transient elastography is below 20 kilopascal and platelet count above 150, there's a very low risk of having varices requiring treatment, and you can avoid screening endoscopy. The interesting thing at that time, when these proposals were made, the level of evidence was quite low, but of course, since many studies, mostly retrospective, validated these criteria. And as a result, about 20% of endoscopy can be safely avoided, missing less than 4% of patients with varices needing treatment. Now, we have a recent meta-analysis that has been published last year, and you can see 13 study, more than 4,000 patients, and the rate of missed varices needing treatment is very low, 0.3%, and the spared endoscopy rate is around 30% or a little bit more. So we can be confident on the recommendation made by Baveno. And as you know, Baveno, there's been another meeting this year. The meeting has been unfortunately postponed to October because of the current ongoing health issue. So what about expanding the Baveno 6 criteria? So liver stiffness of 25 kilopascal and platelet count to 110. This has been proposed by a group of people from Barcelona, Salvador Agustin. And you can see that in total, you increase the number of spare endoscopy, but at the expense of having more patients with missed varices needing treatment. Now, so what is the use in clinical practice? This is probably the most important slide for you. I'm sorry, this is a busy slide. This is a very nice review from Annalisa Bersigotti, published now 3 years ago in the Journal of Hepatology. And if I can have the pointer working, yes. So you're starting of patient with CACLD, and this is according to the cutoff. If it's 10 kilopascal, it's likely. If it's above 15 kilopascal, it's very likely. When you have a confirmed diagnosis of CACLD, you should, of course, question whether there is CSPH, and if liver stiffness is above 20 to 21 kilopascal, this is very likely. If it's in the uncertainty zone, then you might perform HVPG if it is available in your center. Now, the next question is whether you should perform endoscopic screening, and again, if it's above what has been proposed by the Baveno criteria, you should perform endoscopy, and be signed, of course, to the findings for treatment, start non-selective beta blocker. Otherwise, you perform surveillance. So it's quite easy to apply, and now this is really the standard of care. I want to briefly touch on spleen stiffness because there's been quite a lot of study on spleen stiffness, and actually, again, this is a nice figure from the review by Annalisa, and you can see that liver stiffness actually is increased with fibrosis, while fibrosis accumulates in the liver, and it's an indirect reflection of portal hypertension in patients with CACLD, whereas spleen stiffness probably is a more direct reflection of portal hypertension because this is due to congestion and other change related directly to portal hypertension independent of its cause. So there's been quite a lot of research in this area. Also, the proof of concept study started 8 years ago from Italy, and you can see there's a nice correlation with spleen stiffness and HVPG. This was the index study by Antonio Colecchia, investigating liver stiffness and spleen stiffness for CSPH, and I have to say it was not significant as compared to liver stiffness, and same for esophageal varices, but what you can see, because the scale is different, that spleen stiffness is usually much higher than liver stiffness. So the issue is we have several machines to measure spleen stiffness, and you see with the conventional FibroScan, the failure rate is very high, between 13 to 42%, whereas with an ultrasound machine such as RFI or shear wave elastography, it's much lower. So recently, a new dedicated spleen FibroScan has been proposed. This is the only study we have so far comparing with a conventional FibroScan. This comes from the company, so we need more data. The first message, if you look, so the advantage of this machine, the values are not capped because they go above 75 kilopascal, and you can see on the right of the slide. The second advantage is that the failure rate is much higher, 8 versus 24% with a conventional machine. But in terms of performance, only for large esophageal varices, the OROX was significantly higher, but you can see the added value was quite marginal. So in other words, we need external validation because this comes from the company. So we are waiting for more data before we can draw any firm conclusion. What about shear wave? This is again quite a large study comparing for spleen stiffness, and actually it was quite similar between liver stiffness and spleen stiffness using shear wave and FibroScan. So basically the idea is, I don't have time to go too much into detail, but there's a recent meta-analysis showing that for high-risk varices, there's no added value of spleen stiffness as compared to liver stiffness, but the idea is to combine spleen stiffness with liver stiffness using, for instance, this algorithm that has been proposed by Janssen, and you can perform sequentially first liver stiffness, then spleen stiffness to better refine the classification of your patient for CSPH. Now, what about high-risk patients for portal hypertension-related complication? So this is a well-known paper showing that there, of course, many cirrhosis are not all alike. In other words, when you go from the compensated to the decompensated stage, of course, the 5 years mortality increases a lot when you're decompensated. This is no surprise. But liver stiffness using transient elastography has been shown now in many studies to have prognostic value in chronic liver disease, not only in terms of complications, but also in terms of survival. So these are the two index studies from our group that were published now almost 10 years ago, but there have been many studies since confirming this data. Actually, there was a meta-analysis published now in 2013, and you can see again with different studies for complication and survival was clearly related with liver stiffness. In other words, the higher the liver stiffness, the more likely to develop complications and decrease survival. What might be interesting, because this is only based on baseline liver stiffness evaluation, but of course now it's so easy to use that in our clinical practice we repeat liver stiffness over time, let's say every year. And this is again the index study from France, from the group of Corpescio, showing that the delta in liver stiffness over time might be even more important than the baseline liver stiffness value. This is in CSP, so CSP, you have to be cautious because this is a very complex disease. How you can extrapolate this result to other etiology, but still it's an interesting concept. And actually this is a paper from the group of John Janeska in Barcelona, showing that you stratified your patients according to the baseline liver stiffness value, so around 20 kilopascal. And of course, if you're above 20 kilopascal, you're at higher risk. But then what is interesting, you can refine in this subgroup of patients with the delta, the variation, the increase in liver stiffness value by 10%, and this is where patients are the most severe and the most likely to develop complication over time. So coming back to this nice figure, you could use actually liver stiffness to stratify your patients, not only of course for CACLD, but for the risk of developing complication once they reach the stage of CACLD. And for instance, below 20 kilopascal, it's very, very unlikely that they develop complication. They all have compensated cirrhosis. Above 50 kilopascal, most of the patients have developed or are at risk of developing complication. In between, of course, this is a kind of a gray zone. So these are my take-home messages. Liver stiffness by transient elastography using a cutoff of 20 to 25 kilopascal should be considered sufficient to diagnose clinically significant portal hypertension in patients with CACLD. Platelet counts, spleen size, and spleen stiffness can be considered as additional non-invasive tests to further improve risk stratifications for CASPH. In patients with CACLD, Biveno 6 criteria are well validated to exclude high-risk varices and avoid endoscopic screening, and this is the standard of care. Now, regarding spleen stiffness, using transient elastography, it can be used to stratify the likelihood of high-risk varices in patients with CACLD. And finally, in this patient, liver stiffness should be used in addition to liver function tests to predict clinical decompensation and mortality. Thank you very much for your attention.